Good evening, everyone, and welcome. We'll give it a couple more seconds before we start this evening to let folks log into the Zoom room. Well, I think I'm going to get started. So good evening, everyone, and welcome. Welcome back to those who were with us last week, and a new welcome to those who are new for this week. I'm glad everyone is here. My name is Judy Gardner, and I am the Executive Director for NAMI Washtenaw County. And this evening, we're pleased to be presenting the second of this three-part webinar series on navigating a mental health crisis. Tonight, we will be discussing what happens during a mental health crisis. This series is brought to you by NAMI Washtenaw County, Michigan Medicine, and Washtenaw County Community Mental Health. Our panelists this evening are Allison Payne. She's a leader of NAMI Washtenaw County's Parents Together support group, which focuses on supporting parents of children who have suicidal ideation. She will be sharing her story as a parent helping her child through a mental health crisis. The second speaker this evening will be Dr. Scott Mario. He's a clinical assistant professor, and he will be discussing what to do during a crisis for individuals with a mental health condition and their loved ones. How can their loved ones be more supportive, and what are they going through during those times? And last but not least, our third speaker is from Community Mental Health. That is Melissa Tasker. She's a program administrator for crisis in the CARES team, and she will address what to do during a crisis with a focus on the Community Mental Health Access Hotline and the CARES program role. So, of course, we have a wonderful lineup this evening, and we're excited to hear everyone. A couple of things before reminders that I would like to include this evening is please remember to submit questions through the Q&A and to indicate on the question if you want to have your question directed to someone, one of the specifically a specific panelist. If not, I will just decide or kind of call them out and ask them to answer the question. But if you want someone specific, please indicate that in the Q&A. Also, there is all of these questions that you're submitting in the Q&A will be anonymous. So you don't have to worry about that as I moderate the Q&A portion of the program. Well, everyone who is registered for this will receive an email with a link to the recording and slides and resources following this webinar. So now, without further ado, I'd like to introduce Allison Payne, and she will start with her story. Thank you, Allison.
Thank you, Judy. So tonight I'm going to tell the story of what we went through as parents when my son became ill. And since then, I've done an awful lot of talking with NAMI and taking classes, etc., and leading a support group. So I'm going to share with you some things that I wish I had known right away concerning safety, taking care of business, appointments, medications, etc., what we do with the schools, and education, and how we can educate ourselves so that we can handle these crises better for ourselves and our children. So to start with, my son is a very sweet, polite young man, and he was involved in baseball, year-round swimming ever since he was very little, from age 4 to 15. He had good friends, and although he had nightmares and anxiety about spiders, bit his nails a lot, and had many intense stomach aches, nobody ever suggested that mental health was involved. I took him to the ER once when doctors were baffled because they were sure he had appendicitis. His intestinal pain was so strong, but what they didn't appear to know, what we didn't know, and apparently the doctors didn't know, that these are all symptoms of serious anxiety. In elementary school, he had an IEP which is an individualized education plan for speech, and he attended speech therapy. Because of his slight speech impediment, he was bullied terribly when he was a child and when he was on the high school swim team, and he started to exhibit extreme anger, screaming and sobbing in the car on the way home from swim meets, but he wouldn't tell us why. He didn't attract a lot of attention from the schools because he was doing very, very well until he became suicidal at age 15 in 10th grade. Finally, one night after having huge outbursts and suicidal threats, we took him to the psych ER and he spent a week in the hospital. A diagnosis of depression and anxiety finally helped us understand some of his physical manifestations. According to my son, he had been depressed since he was about 9 years old. Considering that many youth aren't diagnosed for years and that some symptoms only begin in college, we were relatively lucky that he was diagnosed while still living at home. Homework and school stress were partially responsible for his condition, but he did make it through high school, as I mentioned, with an IEP that allowed him more time on tests and gave him some other things that he needed to succeed in school. When he was in the hospital the first time, he was so stressed about school and talking about it so much, I had contacted the special ed people at the high school, and they actually managed to get him into a class called the resource room. Taking care of that while he was in the hospital actually decreased his stress incredibly, and I was very lucky that I was able to do that. A later diagnosis of inattentive ADD and major depressive disorder helped explain why my son didn't seem to be able to focus on large assignments, which we had noticed early on in 7th and 8th grade. But finding a medication proved problematic. He did end up going to a private school for 12th grade because regular high school wasn't working well at all. And while it was still a very rough time, and he had one really bad month and a week in the psych unit, he did manage to graduate with a good GPA, a very respectable ACT score, and he went off to college. In the past few years, he has held a job, attended community college part-time. He has a girlfriend, and he's learned to enjoy life a whole lot more than he had before. I did want to say that with proper medication, and he also had a psychiatrist and a therapist, and a lot of support from us and from the people at his private school, he did very well. There is a lot of hope. He still succeeded. Parents are on the job, though, 24/7, and they need the trust and expertise of therapists, doctors, and teachers to help them keep their kids alive. So I deal with, we have a bi-monthly online Zoom meeting parent support group, and I have done this now for 5 years, and I had another group before that. There are some basics that we talk about needing to do when your child is in the hospital. Your child is safe if they're in the hospital, or if it's an adult member of your family or loved one. While they're in the hospital, they're safe and they're getting care, and it's your turn to take care of some business. So if you have a child that has been suicidal, for example, you want to make that house as safe as possible for when they come home, and now's your chance to do it. So go to a hardware store or Lowe's or something like that and buy a locked case that you can put medications in. Then hide the box and hide the key in a different place, and never ever let your child see where you're getting the key from when you fill up their weekly supply of medication, if they have been diagnosed and given medication while they're in the hospital. Most of these medications, some of them can be very dangerous. Most are not incredibly, but in terms of a week supply, you would never want them to have access to their full bottle of medication, that's for sure. You don't want an overdose. Hide all the knives and scissors. This is something that nobody told me, and I wish they had, and you don't think about until you think about it. So put them somewhere that the child won't find them easily. I used to put mine in the oven. did manage to burn up a few, but he would never have thought to look there. You don't want easy access to anything that could be a weapon or could be used to harm themselves. And remove all weapons from the house. And ask nearby relatives to do the same as well. Note that you can sometimes ask your local police to hold on to firearms for you, but also remove things like baseball bats, hockey sticks, swords, things like that. You don't want any weapons in your home. Remove all ropes, razor blades, plastic bags. This can be difficult, but when a child comes home from the hospital, if they've been suicidal, you certainly don't want them to have access to anything like that. Check your kids' phone messages while they're in the hospital and you have their phone, and copy down all the contact info for their friends. This could come in very handy later on. Input the suicide hotline phone number into your phone, 1-800-273-8255. There are also some other local numbers that I'm sure Melissa will tell you about that you will want in your phone. And when your child comes home, you could talk to them about putting the suicide hotline phone number into their phone and do it together to indicate that, you know, if they don't want to talk to you right away, they should call somebody. Hide the car keys at all times. If you have a child who's driving, you don't want them taking off in the middle of the night, which has been done before. Hide the keys during the day and night. I used to put mine in the bottom of a tall pair of boots, and trust me, he would never find them there. He'd never stick his hand down there to find them. Okay, so you've taken care of some business of making your house as safe as you can possibly think of. While your child is in the hospital or your loved one, is now the time also to call your insurance company. Ask specifically what coverage they provide or if prior approvals are necessary. Ask to be assigned to a mental health care manager. This can be very helpful, and they are very good to have on your side. Asking for them and developing a relationship can be important. If you're not covered for long-term inpatient treatment centers, ask them when the next sign-up period is and if this can happen. You never know if you might need something in the future, so if you take care of business now, then it'll be done. When your child leaves the hospital, they will have to have some appointments lined up, so now's a good time to start trying to find a psychiatrist and a social worker, and write it down and keep it handy. Your child may be stressed out about their extracurricular activities. Talk to them and ask them what they would like you to do, and try to take care of it for them. A really important key to having a good relationship with your child and letting them know that you are totally on their side and you are their advocate is to visit them in the hospital when you can, and to review your communication and listening skills so that when your child comes home, you're not fighting and arguing. You don't want to cause them any more stress, and you want to have some expertise in this. And there's a lot of things online about reflective listening. There's also a system called LEAP, which is listen, empathize, agree, and partner. And NAMI actually teaches a class on this. And my own personal that I came up with because I can't remember anything is BLT. Breathe, listen to your child, your loved one, and think before you respond. These are all pointers that I've come up with over the years. I've used them with my child. They're not easy, but taking care of some business can really make you feel that you are empowered to help your loved one so that when they come home from the hospital, they'll be safe, and that you have taken care of something and you're involved in the process. And I also want to put a plug in for a NAMI class, parents, family to family, as well as NAMI basics online, and you can find out about those later. Thank you very much. I'd now like to introduce Dr. Scott Mario.
Thank you, Allison. So just a little refresher, Scott Mario, I'm a clinical assistant professor at the University of Michigan. I focus most of my time working on the inpatient psychiatric unit at Michigan Medicine. but I also float between some other areas like the partial hospitalization program as well. But today I wanted to talk to you about, as the title of the slide say, navigating a mental health crisis, specifically during that crisis. So when we think about what is a crisis, and so the main things that we focus on there are, one, imminent risk, unintentional or intentional, of harm to self. The other, imminent risk of intentional or unintentional harm to others, and both due to mental illness, I should say. And then the other one is like an inability to meet, our basic needs due to mental illness. And so I want to discuss sort of like the stepwise sort of ways that patients and family members can engage in various interventions to address a crisis. So we can move to the next slide. So initial steps in providing support or navigating how to address a crisis. Obviously, we like to start with like the least restrictive means of intervention. So one of the first things can be really helpful for family members specifically is to encourage, a patient with history of mental illness to utilize a previously developed safety plan that has been completed. That's typically done, with a mental health provider. So if there is a safety plan, referring, the loved one to review that. And that's something that they developed. I think it was discussed during the talk last week, during a period of wellness, where they, identify specific, techniques or coping skills that are effective in sort of de-escalating distress. And then also highlighting specific individuals that, social supports that, the patient can reach out to for support. That would be a great place to start if it's not an emergency, obviously. The next step would be encouraging, the patient to reach out to their current mental health providers if they have them. The goal of that would be to see if there a more urgent appointment or some sort of intervention can be completed quickly, whether that's reviewing medication, coming up with more detailed safety planning, or making an appointment sooner than scheduled. That can be very beneficial. The provider knows that the patient and can help sort of navigate the system as well. If those interventions don't work, or there's distress that's ongoing or the crisis continues, that's sort of where we're starting to look at specific crisis resources to sort of escalate the care. And so there are multiple crisis lines available to individuals. Some are phone, I put a couple up here. The National Suicide Hotline, you can call, or there's also text lines that you can use, because I've had many patients say they feel more comfortable texting versus speaking over the phone. There's specific crisis lines for veterans. And then, I think Melissa will touch on some of the Washtenaw community mental health supports, but, there's local crisis lines. And then, a plug for the U of M PES, or Psychiatric Emergencies Services Crisis phone service. That can be very helpful, especially if, a patient has previously engaged with U of M, because then, that's a 24-hour service that you would speak with a social worker and PES, and they would have access to your records and maybe get to know a little bit about what you've been treated with and things that have helped you in the past. So another, intervention, if it's extremely urgent, or there's an emergency going on, don't do any of the things I mentioned above, and just kind of call 911 if it's imminent, and the resources will be sent to the location of the patient and direct the patient to the nearest emergency room for evaluation. I can also mention that sometimes patients can be resistant or not aware of their need for treatment, and so families do have the power to go through the court and petition an individual for an evaluation if they're meeting that criteria, like I said, imminent risk of harm to self, others, or inability to care for self, and ask appropriate judge to basically what's called a pickup order, have the patient brought for an evaluation. That order doesn't mean that the patient would necessarily be admitted to an inpatient hospitalization, but it would require for an evaluation to be completed. So that's sort of the initial steps. And now I kind of want to focus on like what it looks like when you do sort of engage with, emergency services, like in an emergency room, and ultimately if admission is pursued. So we can move to the next slide. So I wanted to focus on what it, oh, could you go back? Yeah, thanks. What it would look like, for, a patient and for their family to sort of engage in an emergency mental health evaluation. So the goal of that evaluation is basically to determine what is the next necessary level of care for that individual based on, the crisis that's going on. And so the location for these assessments are either, in emergency rooms. It could be a general adult or pediatric emergency room, or at some facilities like U of M, there's designated psychiatric emergency services. And so what you can expect in these interactions is to have an evaluation completed by a physician, typically. That could be an ER physician or a psychiatrist, depending on the location that the evaluation takes place. And then typically a clinical social worker is involved in the case as well. And how a family member and a social support can really be engaged is definitely obviously supporting that individual. With COVID, there are some restrictions about having loved ones stay with you in the emergency area sometimes. With minors, they definitely can have one individual, at least at our psychiatric emergency services, but adults do go in alone, unfortunately. But that's always changing with COVID. Other ways that they can be, very helpful. Family members are usually contacted to provide collateral information to kind of gain further insight into what's been going on with the patient presenting with the crisis. That can be very helpful, as sometimes patients that we interact with might be minimizing their presentation, and we like to confirm what's really going on from another perspective. And then if discharge or is something on the table after this evaluation is done, family members, as Allison really reviewed, can be, so helpful in the safety planning aspect of the evaluation and plan, and that would be reviewing how to create a safe environment at home, what level of observations are needed, and making sure that they are aware of the follow-up care that has been recommended for the individual that had the evaluation for the crisis. But basically the outcomes of these emergency psychiatric evaluations are there's sort of two outcomes. One is that the patient will be discharged back to the community or home. Oftentimes that discharge doesn't mean they just return to their previous, plan. They can still escalate care. So oftentimes there could be a recommendation for more frequent outpatient visits. There could be a recommendation for like a partial hospitalization program that would occur as an outpatient. So that's one step. Another option is admission to an inpatient psychiatric facility. And, something that often happens is that based on the location of, presentation, whether that's, an outside hospital ER or like here at U of M in PES, there's not always a bed available at that facility if admission is recommended. And sometimes loved ones will be transferred out throughout, Southeast Michigan typically. So I know that can be very, difficult for some families when they come to like the University of Michigan and then have their loved one sent to another hospital, but that happens unfortunately due to availability. So next I want to focus on what it looks like for the individual and the family when a person is admitted to the unit. So we can move to the next slide. So during an inpatient hospitalization, the primary goal of treatment is to, stabilize the mental health crisis. Something I talk to my patients about very frequently is that at the time of discharge from an inpatient admission, you're not necessarily going to leave the unit maybe 100% back to your usual self. That can take some time. and further treatment as an outpatient. But the goal is to make sure that you can transition out of the hospital, which is a very restrictive environment, which we'll talk about in a second. The goal is that you leave, safe, that the crisis of the imminent risk of harm to self, others, or innovative care for self have been addressed, and there's a plan moving forward on how to treat other aspects of the mental health presentation. In addition to the stabilization, the goal is to sort of understand the diagnosis through assessments, develop a treatment plan of how to provide care in the inpatient setting, and then how to continue once discharge is achieved. And then coordinating care for further mental health treatment. Everyone that leaves the inpatient psychiatric unit will have an appointment with a mental health provider within 7 days of discharge to support a safe transition out of the hospital. I should mention, we also do, if there is already established care as an outpatient while they're on the inpatient unit, we'd be coordinating with that team as well. So what to expect, really, like who are the loved ones with the mental health crisis going to interface with? So on an inpatient setting, they will meet with a psychiatrist. If it's a training facility, they will see an attending psychiatrist, and they will also see sometimes a resident psychiatrist, and there could be medical students involved or other trainees. There's also nursing staff that will meet with the patient frequently throughout the day. Social workers that meet with the patient to address social needs, and then they're really in charge of helping set up the aftercare, especially. There's also different types of therapies, so activity therapy, occupational therapy throughout the day, so they would interface with those individuals as well. Some of the restrictions, this comes up a lot, like what does it really look like on an inpatient unit? They are typically locked settings. So an individual admitted to an inpatient facility, their rights have some restriction, meaning that they can't just leave as they please typically. And there's a difference between like an involuntary status and a voluntary status, which we can discuss if people have further questions on. I'm happy to go over that later. But there are visitations allowed, even though it is a locked setting, so family members can visit. I would really recommend, if you do have a loved one that, is currently or, in the future admitted to an inpatient unit, really speaking with the facility, the social workers at the specific hospital to gain an understanding of what their COVID visitation procedures, sort of what the hospital is using to determine what types of visitations are allowed, because it changes frequently. But we do encourage family visits. Outside of visits, the patients are going to groups throughout the day to learn various coping skills. They meet with the psychiatrist to review medication management, if that's something that is on the table for their treatment plan. And like I said, we coordinate with if there is current care as an outpatient, coordinating with those providers. And then the length of stay, obviously varies between individuals, but average length of stay is around 5 to 7 days in an inpatient unit, sometimes shorter, sometimes longer, but that's sort of an average. And that's, specifically for adults, children sometimes may be sometimes longer, shorter, but I focus with adults, so that's my area of expertise. But how can a family member really be supportive in this setting, or what role do they play in their treatment while there's the inpatient treatment going on? Again, support. So the patients have access to phones, frequent calls, check-ins on how they're doing, obviously can be very therapeutic. Visitations, if that's possible. And then again, just like I mentioned, during an emergency psychiatric evaluation, providing collateral about what's been going at home to the inpatient team can be very helpful. And then we oftentimes use the information, like if you are speaking to your loved one frequently, with phone calls or visitations, we like to get some feedback, on how does the patient appear to the family member, the social support, how close are they to their baseline level of functioning? That can be very valuable information for the team to know. And then again, like we talked about earlier in the emergency psychiatric setting, if there is a plan when the plan for discharge is set, the family can be so important in the safety planning aspects of, again, securing weapons, if that's the case, making the home environment safe, removing excess stockpiles of medications that the patient may have accumulated, and then really being aware of the like follow-up plan, so that, you know, they can sort of make sure that, you know, the individual is engaging with treatment once they leave the hospital, and that the care continues. And so I know that there can be a lot of stigma about what it looks like on a inpatient setting, but, you know, families are so encouraged to be part of the treatment team, and, you know, the patients do have, you know, activities throughout the day and supports there, but it can be a challenging experience, especially during, you know, a person's, if it's their first admission, it can be, you know, an adjustment. But those were the points that I wanted to cover, and, you know, happy to answer questions going forward if people want specifics on, you know, either the psychiatric emergency setting or the inpatient setting. But I wanted to turn it over to Melissa Tasker to kind of wrap up our initial panel discussion.
Thanks, Scott. Hi, everyone. I'm Melissa Tasker. I work for Washtenaw County Community Mental Health, and I am the program administrator over our 24/7 mobile crisis team, as well as our access department and our cares team. I've worked for community mental health for the last 10 years, and I've been a part of our crisis team for the last 7 years. First of all, before I get started, I just want to thank Allison for sharing her story with her and her son. That was really, really great information that she gave. And it's something that I even wrote down to tell our families that we talked to. So thank you so much. And thanks for Scott for providing all the information on what happens when you get to the ER and on a psych unit. So I'm going to talk about our crisis team. If you want to go to the next slide. Thank you. So this is our number. I'm going to leave it up here for a while. This is our 24-hour crisis line. So you can call this number pretty much if you're looking for anything. If you're looking for outpatient treatment, if you're looking to get connected to community mental health, if you're looking for information about mental illness and about mental health treatment, or if you're in a mental health crisis and you need immediate assistance, you can call this number. It's 24 hours a day, 7 days a week. We have master's level clinicians who are trained and have lots of experience to talk to individuals who are in a mental health crisis, to talk to family members whose loved ones are in a mental health crisis around the clock. So if you call that number and ask to speak to the crisis team, you will be connected with someone who can help you. And I'll talk a little bit about what our crisis team can do for you. But first I want to talk about, you know, what happens when you are in a mental health crisis. If you are the one that's in a crisis or your loved one is, it can be really scary. You know, oftentimes, most of the time, it's hard to know what to do next. And so it's easy to panic and get upset, especially if you're watching your loved one struggle. But I'm here to offer our support, because while it may seem impossible or scary or difficult to navigate, which it is, the mental health system can be, if you call our number, we can help you navigate through your current crisis. If you're the one going through a crisis, or we can help you navigate on how to help your family member. You know, examples are if your family member is suicidal, if they're struggling with symptoms of depression, if they haven't left the house in days, if you've noticed that they haven't been sleeping, if you notice that they, you know, are doing a number of things and you just want information, you're not really sure what to do, you're not really sure if what's going on is problematic, you're not really sure, you can call us and we can walk you through that too. If you yourself are going through a mental health crisis or are experiencing something that you just want information on, what does this mean? What can I do to help myself? You know, we can also help with that as well. If you want to go to the next slide. Thank you. So this is just some quick facts about our crisis team, and then I'll talk more about everything that we can do. So like I said before, it's made up of our master's level clinicians. And also this team is a mobile crisis team. So while we can answer, we do a lot of work over the phone. You know, we take a lot of calls from individuals who are looking for information, who are looking for help, and we talk to them and guide them through what's going on. We also do a lot of outreaches in the community. Just last month, our crisis team saw individuals well over 200 times in a month. So we are going out in the community and we are responding to individuals at their homes. We go to primary care doctors' offices. We go to businesses, anywhere that someone is at that is in a crisis, we can go and see them. And the benefit of this is that, you know, we can meet you there. We can conduct our own clinical interview. We can determine if what needs to happen. Like Dr. Mario was talking about before about safety planning, we can help safety plan and create that with you or with you and their family, which includes, you know, outpatient care, how to keep them safe, what we need to do to get rid of or reduce the amount of risk that could be that could exist at home or in the community. Our goal is to really try to help the individual stay in the community while at the same time keep them safe. And sometimes that's not possible. Sometimes the person really needs to be on a psych unit. And if that is the case, then we can help pursue that too. This is a team that also helps families get petitions or walks through that pickup order process for that involuntary admission that sometimes needs to happen. Anyone in the county can access our number. So regardless of what type of insurance you have, if you have private insurance, Medicaid, no insurance, you can call us and we can provide you this service. So what we do when we get there, we do a real-time mental health assessment. So we're assessing for mental health symptoms. We're assessing for how well they're functioning in the community. Have they all of a sudden stopped working? Have they found it a hard time going to school? What's going on? Is there a way for us to provide or authorize or guide someone to a lower level of care, like a partial hospitalization program, or an outpatient setting? What can we do to help the family or the person? I also want to talk about how we do correspond with law enforcement when we need to. Oftentimes law enforcement will get called out to a scene and they will call us and we will correspond with them. We'll meet them out to the scene to really help guide what needs to happen next, because we really are the experts in mental illness and mental health care. And law enforcement do get called because when you call 911, oftentimes it is a law enforcement officer that's going to be responding. But we've been working really closely with our local law enforcement to be involved in those call outs because they do recognize that they are not oftentimes the experts on what to do. So they will call us for assistance. And sometimes, you know, we call them because, you know, if we're going into a situation where maybe there's a history of, you know, that residence or that place being unsafe, or if it's in the middle of the night, or there's lots of factors that sometimes we will call just to help keep our clinicians safe and keep everyone safe. So sometimes that happens too. But the big thing is that, you know, we want to respond so that we can help navigate these situations, which are oftentimes really scary. It's really tough. And we can be there to kind of help support family members and support individuals through this process so that it's not so scary. Okay, go to the next slide. Great, thank you. Okay, so our CARES team is a extension of community mental health, and it is a team that is used to stabilize individuals who are often coming off of a psych unit who can't find mental health treatment in the community, or individuals who are struggling with mental health symptoms that can't find treatment in the community, because there is a lot of most community providers have wait lists to see a psychiatrist, to see a therapist. And this team's goal is to provide stabilization services. So case management, peer support, psychiatry. We do provide brief therapy, but a lot of what we do is that case management piece, which is making sure people have housing, making sure people have everything they need to have a good quality of life, to make sure their meds are taken care of, to make sure that everything that they need is taken care of. We help people get employment. We help people navigate through the DHS system. We help them with a lot of that. And we're able to stabilize, and we've actually been able to stabilize folks, and then they've been able to move on to a longer term care setting, or back to their primary care doctor. So the CARES team can serve anyone regardless of their insurance. So this team, there's really no criteria except for these individuals don't need community mental health treatment, which is serving folks who have a severe mental illness that's oftentimes chronic. This team is our goal is for really short-term treatment and stabilization while people are waiting, because what our crisis team saw over time was that we would see people in crisis and we would follow them while they were working through their crisis, but sometimes they would find themselves returning to the hospital because they weren't able to find mental health care in the community. And so the goal of this team is to prevent that from happening. One thing that I forgot to mention was that our crisis team does a lot of follow-up. So if you're a family member and you call us, we put you on we have a large crisis board that we go over 3 times a day, and we are following up with families. We're following up with individuals every single day to check on their mental status. What's their mood like? Are they having thoughts of wanting to hurt themselves? Were they able to connect to that agency? Were they able to get their meds refilled? How are they doing today? How can we help them follow their safety plan? We do that every day until the person is outside of their crisis. And so at any time anyone calls, that is what we're doing. We do a lot of safety planning for folks who come off of the psych unit. We do a lot of safety planning for folks who are in the ER, and we are trying to divert them home so that they can be safe and while continuing to be in the community. So that is a lot of the services that we provide with our crisis team. So, and that is all I have.
Well, thank you, Melissa. That was fantastic. To everyone, but all of our panelists tonight, I want to thank you very much. That information was even good for me to hear, even though I know much of it. It's always good to hear it again and remember those things when I'm also answering calls for the organization. So right now we're going to go into our Q&A session. I want to encourage all those folks who have questions to please submit them in the Q&A portion in your question and answer box here for this Zoom call. Were you done, Melissa? Okay, good. Okay, good. Just wanted to make sure. I'm seeing a little different than what our guests are seeing this evening. So I want to start with, since we ended with Melissa, I do want to defer our first question in the Q&A box to you. Someone asked, I know that crisis team cannot come in person to other counties, but can anyone from any county call for information or navigation of the system for help? Or how to, I guess they're asking, can we call Washtenaw County if I'm outside of this county for help or questions?
Yeah, absolutely. You can call, and we know very well the mental health CMH systems in Lenawee, Livingston, and Monroe counties. And we also have a direct connection to their emergency service workers after hours, so that we can definitely connect you there, but we can help navigate and, look through what options that exist in other counties for sure.
That's fantastic, because I was wondering that myself when I saw that come up in the box.
Yeah.
We're very fortunate here in Washtenaw County to have this service and to have community mental health and this public safety and millage to provide the funding for that. So I have another question in the chat box. Someone is asking, what do I do if I have an adult that doesn't think that they need to be hospitalized? They won't call the crisis center because they don't want their phone to be tracked, and they won't go to the hospital. So I really want to help. So who wants to tackle that one for us?
I mean, I can mention some thoughts, and maybe Melissa can also fill in some gaps too.
Wonderful.
And so kind of referencing back to, the initial part of my discussion, defining the crisis. So for some individuals, obviously, are going to be resistant to engaging with the mental health treatment system, whether because they don't view that they have an issue or they don't have the capacity to understand the need for that. There can be various reasons for why an individual might not engage. But if they meet a standard of, imminent risk of harm to self, imminent risk of harm to others, or inability to, meet their basic needs, all due to a mental illness, family members or social supports, with the support of, agencies like, Washtenaw CMH and the crisis team, can pursue going to the probate court and seeking a petition for mental health treatment. What that entails is providing, justification for meeting one of those, criteria that would initiate in sort of an involuntary psychiatric evaluation. And then if that is granted by the probate court judge, that initiates a pickup order, and the individual, would be brought to the hospital involuntarily for an evaluation. And then in the emergency services environment, they would interface with those providers I mentioned, social workers, physicians, typically a psychiatrist, to determine if they need further treatment based on that evaluation. And so there is a process to do that. And I saw something pop up is a petition only for like a child. No, this is for adults as well. They just have to meet that standard of, the specific criteria. I want to see if Melissa had any further comments on that process.
Sure. Yeah. And it's actually our team that would help walk you through that probate court process. So we are the designated team to make sure that all the forms are filled out. What I would recommend is if you have a family member who doesn't want to go to the hospital and isn't really interested in engaging in mental health treatment, is to call us to talk to us about what that person is going through and what symptoms they're currently having, so that we can guide you to say, it sounds like they really do need to go to the hospital, or, it doesn't sound like there's enough there for us to really pursue an involuntary hospital admission. And then we can talk about what to do next. I know our crisis team has peer support specialists, and their role is to really help engage folks who are nervous about mental health treatment, who have maybe had a really bad experience in the past or really having a hard time. And so we have those folks on our team who we utilize frequently to just talk to people to say, hey, how's it going, on a real non-threatening level. But our goal is to really meet people where they are. And it's not to always, get them to the hospital unless they really need it. Most people can be treated in the community. So that's our goal. But I would recommend giving us a call, and we can really get to the bottom of what the best next steps are.
I have one suggestion as well. We use this book in NAMI. I don't know if it'll show up clearly. I guess not. It's called I Am Not Sick, I Don't Need Help. And it's by Xavier Amador. And it's to help the seriously mentally ill accept treatment. And this is also part of the book that talks about the communication skills that I mentioned, the LEAP method. So if you like having something physical in a book to look at, as well as talking to community mental health, then I recommend looking up that book. It might be in the library. I'm Not Sick, I Don't Need Help.
Thank you so much, Allison, and of course, Melissa and Dr. Mario. Allison, I'm going to come back to you, but I'm going to run over to go to Melissa to piggyback kind of what you were just talking about, having folks call you when they're just really not sure where their loved one is in this crisis. So we had a question last week, and I'm going to, and it came up last week, and it's coming up again. And so this person is asking, when to call 911. Okay, there are lots of examples of police making the situation worse rather than better. Melissa, can you talk a little bit about what we could do when we're not sure if we should call 911 or not?
Yes. So I would say, so first of all, our crisis team can outreach to you where you are, but we are not a first responder, and that, you know, we can't travel anywhere lights and sirens. It's going to take about 30 minutes for us to get to you. So I would say if the person is in a crisis such that they've already hurt themselves, or they're imminently at risk of hurting themselves, like they are holding a weapon, or if they've ingested pills, if they are imminently at risk of harm, you want to call 911 because you want someone to get there as soon as possible. I would say that is when you want to call 911 for sure. If you feel like there's time and that your loved one has expressed some, you know, thoughts of wanting to hurt themselves, or they're experiencing a mental health symptoms, but there's no imminent risk of harm and we have time to get there, please call us, and that would be the time. But otherwise, law enforcement and EMS can get there in a matter of minutes, and that's really what you want help with. So that is what kind of how I would distinguish when to call which entity. Thank
you, Melissa. Safety first, all times. All right, Allison, I'd like to kind of come back to you. And we had a question in the chat. Can you tell us briefly a little bit about LEAP, and also what it means to have anosognosia?
Okay, anosognosia is when somebody does not accept that they have a mental health condition. And the author of this book had a brother who did not accept his diagnosis and refused treatment. So LEAP is the method that he came up with for communicating. And it's very handy. And actually a friend of mine used it when her son was having a crisis in a different country and she had to fly there. She called me and I told her about the LEAP method because I had just taken the class through NAMI. And LEAP is listen. So listen to the person, empathize with their situation, agree with them and accept what they are saying, and partner with them for a solution that they feel comfortable with. So it's not the only way to speak to somebody in a mental health crisis by any means, but if you look through this book and read it, I think it will fit a lot of different situations, and different people could be able to utilize it for their own situation. I use various methods with parents because there's a lot of teens, obviously, and young adults who don't think that they're sick and need help. So they read the book, they learn how to communicate with a person who doesn't think that they're sick and doesn't think that they need treatment. And treatments are different, like Scott was saying, and Melissa. There's many different things that can be done in the community, in your own home, without going to the emergency room. So learning how to speak to people to get exactly what they need and what they think they need, and maybe direct them towards a higher level of care is very important.
Fantastic. Thank you so much for that, Allison. I'm going to ask a couple more questions and then we'll have to probably close up. There was a question that had come through, and I'm going to like to direct this to Dr. Mario. There's some confusion around voluntary and involuntary. And I know we talked about that earlier, but during a crisis, for example, if the crisis team goes and gets someone who's clearly in crisis, the police doesn't have to come, the crisis team gets them to the hospital and they don't want to stay. Do you have to have that order in place before they can be forced to stay? That's pretty much what the question is here.
Yeah, so if I understand the question correctly, once a individual is, in, a psychiatric emergency setting or emergency department, with a psychiatric evaluation, you don't necessarily have to have that court order from the judge, because the purpose of that order is to bring them for that evaluation. And so once they're in that emergency room setting, they are seen by those providers I mentioned, a social worker typically and a physician, whether an ER physician or a psychiatrist. And it's the job during those evaluations to determine if they meet that legal criteria for involuntary hospitalization, if they're resistant to accepting a voluntary admission. And after that evaluation, if they meet that standard, then the physician will complete what's called a clinical certificate, which is a document that can hold the patient involuntarily for admission. And then typically a social worker or maybe someone from the crisis team that brought the patient to the hospital, or the emergency dispatch person, like a police officer, et cetera, they can also fill out that petition too. And so those two documents, the petition and then the clinical certificate, hold the patient involuntarily for an admission. And then if while they're on the inpatient setting, they're seen by a psychiatrist on the inpatient unit that evaluates the individual. And if they feel like they meet that standard, they complete a second certificate. And then those two certificates and a petition will be sent to the probate court for the county that the patient resides in. And a court hearing will be scheduled to determine if the patient meets that standard. The judge decides whether or not the patient stays in the hospital and receives treatment, or they are discharged from the hospital.
Fantastic. That was some great information. Thank you so much, Doctor. We have about 1 minute, and I'd like to ask the panel here, is there anything that you think that has come into your mind that we didn't share, that you just coming up for you, that you'd like to share before we close out?
I would. There was a question about calling 911, and there's so much fear these days. But if your loved one is might harm themselves or might harm you, absolutely call 911. But if it is a mental health situation and there's been a diagnosis, remember to tell the person on the line that it's a mental health situation. Also tell them if there are weapons in the house or not. If you honestly know that there is a gun that they might have, then you have to tell them that. Or if there absolutely are no guns, tell them that as well, because that will change how they respond to the 911 call. It could be very different. It's also really, really handy if you have a list of the medications that the person is on, as well as their diagnosis, their doctor's phone number, their therapist's phone number. Have it written down somewhere so that you can give it to them. Have a medical release form. If you have had a medical release form signed in the past, have that handy. If your loved one has a patient portal with their hospital or caregivers, have that release form on the portal so that you can speak with the doctors, because HIPAA laws get involved, and that can really shut down your communication with the team if they take your child once they're over 18 years old. So having some things prepared ahead of time and knowing what you're going to do if you do call 911, practice. Okay, if I have to call 911, I've got this information, that information, and I know where it is. You're not going to call 911 just to scare somebody. You're going to call them to help them. So let them know that that is the situation. But again, let the police know it's a mental health situation. Let them know a diagnosis. Let them know if there are weapons in the house. A friend of mine's a police officer, and we've talked about this extensively. And I think those are all some pretty simple things to keep in mind.
Wonderful. Thank you so much, Allison. And we're going to have to close. We only have 1 more minute. That was fantastic information. Of course, thank you again to our panelists tonight. And thank you all for joining us and asking such great questions. Also, a big thank you to the folks that are behind the scenes that are doing this, Fawn and Maria and Kat from Michigan Medicine. I wanted to just throw that out to them this evening. They're folks that do this behind the scenes, and they do a lot of work to present this to do this for our group. Also, if you're interested in learning more about other organizations behind this series, please visit their websites through the links in the chat. We will also be sending, again, an email with the webinar recording, resources, and slides soon. If you have any questions that were not answered during this webinar, please email them to communications@namiwc.org. I want to again thank you all for joining us this evening, and we look forward to seeing you next Thursday at the same time for our final presentation for After a Crisis. So good night all, and thank you very much for joining us.